Good afternoon, everyone. My name is Brian Hendricks. I'm with United South and Eastern Tribes, and this is the Infectious Disease ECHO for what month are we in? September? So September 11th, 2024. And I'll turn it over to Emily to give some housekeeping information. And let me pull up the slides.
Go for it. Good afternoon, everyone. I'm sharing a link in the chat, which I will throughout the hour. And you also will be redirected after the ECHO is concluded.
Oh.
If you would like continuing education units, please ignore Brian's emails. If you'd like continuing education units for medical or nursing credits, we're offering those today. We're also offering completion credit. In order to receive those, you need to complete the learner evaluation. We also love feedback, so even if you don't want credit for being with us, please go ahead and fill out the evaluation. You also can claim credits within the next 2 weeks, I believe, if you watch the recorded YouTube session. And you are being recorded. The recording will be available within the week. As far as disclosures, this session is jointly provided by USET and Cardia Services. Cardia helps us provide the continuing education units. You can receive 1 credit. Next slide. Dr. Jorge Mera received an honorarium from AbbVie Pharmaceuticals for being on the Speakers Bureau. He's also PI for clinical trials for Gilead Sciences, Merck, and AbbVie Pharmaceuticals. All relevant financial relationships have been mitigated. Emily Field, myself, has a relevant financial relationship with healthcarewarehouse.com, Unilever, and Pfizer. Also, all relevant financial relationships have been mitigated. And as I mentioned earlier, in order to get continuing education units, you need to stay with us for the hour or watch the whole recording and complete the online evaluation. If you have any questions, please contact Steffi at Cardia Services or contact any of the USET staff and we will forward along your question. And please go ahead and introduce yourself in the chat if you haven't done so already. Thanks.
Hi, Dr. Mera. Hi, Brianna.
Good morning.
Hi there.
Let's see. We will talk today about syphilis is the topic, and Anna is going to give some epidemiology, and then we'll switch over to Dr. Mera, who will give more of the clinical aspect of syphilis. So Anna, if you would like to share your slides. Oh, and let me introduce Jewel Hunt. She is the infectious disease specialist, infectious disease manager here at USET. So she is going to be taking over these infectious disease echoes as I will be stepping aside to my new role. So go ahead and take it away, Anna.
Thank you. Jewel, did you want to say anything while I'm getting my slides pulled up here?
Sure. Just hi, everyone. Thank you for joining. Thank you, Dr. Mera, so much, so much. And looking forward to working with you even more in the future.
Perfect. Thank you. So this is just syphilis within the USET region. I know Dr. Mera is going to speak a lot more in depth on kind of the epidemiology of syphilis, clinical practices, testing, treatment, all of that. This is really just meant to be kind of an overview of what is going on within the region. So, without further ado, I guess I'm Anna Garrett, the senior epidemiologist here at USET. So the metrics I'm about to share are pulled from 14 USET member tribal nations. Those indicated 2023 are from the entire calendar year of 2023, so January 1st to December 31st of last year. And then the metrics indicated 2024 are from January 1st of 2024 to July 1st of 2024. So this data was pulled back in July. So we went ahead and have a year period for 2023 and then about 6 months for 2024. We'll get into this a little bit more in depth, but just going over some of these definitions. So for screening, we went ahead in RPMS and looked at laboratory tests. We mainly looked at the RPR, VDRL, and then syphilis, IgG antibody tests. Each tribal nation was sent their specific clinical data back with a full list of these laboratory tests and panels that we had used. These are just the main three that were consistent for all. We also looked at syphilis diagnoses. That was through the purpose of visit within RPMS. And then that was based on a pre-existing syphilis taxonomy that included all of the different ICD codes for all of, the syphilis kind of diagnoses and then associated diagnoses. I also pulled metrics for congenital syphilis, so syphilis in babies. And again, I used an existing taxonomy for those ICD codes as well. So this will be consistent throughout all the metrics I'm about to show. So for syphilis screening within the USET region, and again, this is only 14 tribal nations, so not all of our 33, just a subset of these that we do have existing RPMS access to. So for 2023, we have a few different metrics here. So about 7% of all patients seen in the clinic did get a syphilis screening test of some kind. Patients age range from 12 to 88 years. So we have a very kind of broad age range there. So that's really good to see that we're not just focusing on specific populations. As you may be aware, IHS has put out earlier this year that we are in a syphilis and congenital syphilis epidemic. So the testing and screening recommendations have been expanded to everyone. In 2024, the first 6 months, we have 4.7% of patients screened. You will notice the ends here. This is just the actual number of patients screened divided all of the patients screened or the patients seen in the clinic. So we're seeing here we had about 2,300 patients screened in 2023. And then in the first 6 months of 2024, about 1,400 screened. We can see here that the age range was 8 months to 88 years. Over here on the right-hand side, if you can see this, this is the syphilis screening comparing the years. You'll note that 2023 is including 12 months, 2024 is including 6 months, so that's why this is a little bit lower. What we're mainly looking at here is primarily the screening is taking place in females, but we are seeing this in males as well. So this is just a breakdown of the number of patients screened by gender. On to syphilis diagnoses. In 2023, we're seeing 0.06% of all patients diagnosed with syphilis. So that's anyone who walked in the clinic who got diagnosed. So 22 diagnoses in 2023. That rate is 0.65 new syphilis diagnoses per 1,000 people. Now, if we want a little bit more specific rate of those, who were diagnosed with syphilis, of those screened, that is 0.93%. And that rate is 9.26 new syphilis diagnoses per 1,000 people screened in 2023. And that age range is 21 to 70 years. For 2024, those same metrics, we are seeing 0.04% of all patients diagnosed with syphilis. There were 12 diagnoses so far in the first 6 months of 2024. That rate is 0.41 new syphilis diagnoses per 1,000 people. Again, that's, anyone walking in the clinic. And then specifically of those screened for syphilis, 0.86% were diagnosed with syphilis. So that is 8.56 new syphilis diagnoses per 1,000 people screened. And that age range so far this year is 21 to 39 years old. We're seeing the same breakdown on the right-hand side here of syphilis diagnoses by year separated out by gender. We have female in gray and then male in red. Again, 2023 is a full year, which is why, this is much higher. 22, and then in 2024, this is only the first 6 months. That's why that's a little bit lower at 12. So we're just seeing, going back, we're seeing that the screening is a majority of female, but some male, and then the diagnoses are following that same kind of trend there. Speaking about congenital syphilis, in 2023, we had 0.23% of all newborns diagnosed with congenital syphilis. That was 1 within the region for last year. That's a rate of 2.34 congenital syphilis diagnoses per 1,000 newborns. In 2024, we have not had any diagnosed yet in the first 6 months, so we have a 0%, diagnoses rate and then 0 diagnoses. I do want to note that screening rates are pretty low for syphilis, so it may not be that there are this number of diagnoses. This is just what we're picking up within our PMS, based on the screening that has been done. The final metric I'm going to speak on is syphilis in pregnant women. So that would be correlated to the congenital syphilis that we're seeing in the newborns. In 2023, 0.32% of all pregnant women were diagnosed with syphilis. So that was 2 of 633 in 2023 for a rate of 3.16 syphilis diagnoses per 1,000 pregnant women. That age range was from 22 to 29 years. And then looking in the first 6 months of 2024, 0.25% of all pregnant women were diagnosed with syphilis. So that was just 1 person out of 397 pregnant women. That is a rate of 2.52 syphilis diagnoses per 1,000 pregnant women. And that person was 26 years old. So that's kind of the brief overview of what's going on regarding syphilis, screening, diagnoses, within these 14 member tribal nations clinics. Again, this is just kind of a brief overview, so you're definitely able to ask questions, but I know Dr. Mera is going to get into a lot more depth. This was just kind of meant to frame the excellent presentation we're about to see. You can reach the entire USET Epi team at usetepi@usetain.org. You can message me in the chat, or you can email me specifically.
Hi, Anna, great presentation. And I have a question, if I may.
Of course.
Or a comment. Well, first, that's great data that you pulled. It's difficult to get good data. But one thing I noticed is that your screening rates after the IHS recommendation came out are extremely low. So question is, did you mention that this is is there a health reminder that triggers this in the system for the providers to screen?
Yes. So Brian, did you want to speak more of how potentially the results aren't getting in there? Because I know we had some where we saw the diagnoses, but the lab result wasn't entered in correctly. It was just in notes. So I don't know, Brian, if you want to just briefly give an overview kind of on those issues. You're also muted.
Sure. So we ran into a couple of issues that we found. Some were that a lot of our clinics don't have a full lab, so they send out their lab work, and they were just scanning that document back in instead of entering it in, so that's not getting captured. And also the taxonomies are all blank across our area for syphilis screening. So we need to go in and update those, which we're doing now.
Okay.
So those are the two issues.
So
it's
it
not
may be an underrepresentation of what's actually happening.
Yes.
Because it's a data pull issue. I mean, you can't pull the data because you can't pull those scanned reports or whatever.
Correct.
Okay, well, that's a little bit more comforting because that means that more patients are getting screened. No, and the reason I was asking, because we launched this at Cherokee Nation, and just to give you an idea, before we launched the universal screening, we had about 300 or 400 tests per month, individual patients. But these tests were usually triggered either because they were pregnant, and that's part of the protocol of OB to screen, or because they're on PrEP, and that's part of the protocol to screen them for syphilis and HIV PrEP, or because the provider was suspecting syphilis and they thought it was not a screening, it was a test. It was like, I want to test this patient just to make sure their rash is not syphilis. So when we turned on the electronic healthcare reminder, with one caveat, and I'll mention that later, we went from 400 tests a month to 4,000 tests a month. It was a tenfold increase, and it has been maintained until a month ago for sure. So and this was in September, so we probably have screened about, I would say 40,000 or 50,000 people out of the denominator is about 100,000. So I would say 40% have been screened. Now we do have something that most people, or we had until 3 weeks ago, we had to turn it off for a technical issue, but we'll get it back. Something called lab triggered screening, meaning if anybody has a lab drawn for whatever reason, the cholesterol, diabetes, CBC, and the electronic health system can check if a syphilis test is due or not based on the health reminder. So is this patient due for syphilis? And if it is, it'll drop the order automatically. So the test will be done. Now, it had to be stopped for a technical issue about informed consents because the electronic health record does capture if the patient has an up-to-date signed informed consent, which it actually spelled out you're going to be tested for HIV, hepatitis C, and syphilis. But if it couldn't pick up if the patient had opted not to get that done, which happens, I will tell you, in 3 patients every year out of 100,000 that are coming in. But that someone complained and generated an issue. So IT is trying to fix it in a way that they can capture that, I don't want to get the test done. And that's why we went into a pause. I don't know how much that's going to impact the screening, and I'm sure it will, because a lot of that screening was done, especially in the ER and urgent care, was being done through that system. But anyway, so we increased tenfold the screening rates, and we increased twofold the case detection rates, because a lot of I'm sorry, not twofold, 80% increase in case detection rates. And why the difference? Because when you're screening with a treponema antibody, you're going to pick up everybody who ever had syphilis in their lives. And so a lot of patients, when we looked at the chart, okay, this patient was treated 2 years ago and they're fine, and they don't, it's not a new case of syphilis, it's just someone that now we know they had syphilis. So you have to weed those out. But anyways, it's been very useful. So I do encourage you, to try to get the real deal number, because that way you can tell if screening is really happening or not. And if it is, great. And if it's not, then you need to do something about it, which is tough because it's either education or incentives, or I don't know, put it part of their scorecard, or have someone else, not the provider, order the test, but have the nurse or the medical assistant in charge of ordering those tests, and have the provider just sign it off at the end of the day.
Yeah.
Now, that was my only comment. So yeah, great data. One thing I want to clarify, I had pulled out, I thought you were going to give the other epi part, and I pulled out my slides of that epi part, but I can still mention them. It's 2 or 3 major things. I just want to take a deeper dive on the clinical part. Okay, I'll stop there, and I don't know, let me know when you want me to start.
I'm good with you going ahead and starting.
Okay, let me. Okay, where's the share button here? Give me 1 second.
Dr. Mara, are y'all on RPMS at Cherokee Nation?
No, we're on Cerner.
Okay.
Okay. Can you see my presentation? Okay. Okay, so I'm going to cover a little bit about the syndemic component of syphilis, a little bit about trypanomatosis in general, and then I'll take a deeper dive on syphilis. And well, this is just an intentional disclosure slide that we started incorporating, that, we are aware that language is evolving, and sometimes we may use a word that offends someone, and just please let me know. Not during the presentation, though, don't embarrass me in front of everybody, but send me an email or a text, and I'll change that word if it's not appropriate. I don't think we'll see. There are some images here, I just want to warn you, that are sexually explicit. Okay, so it is important to understand that syphilis is part of a syndemic. It's not happening by itself out of the blue. And I think it's really tied to, based on the publications, it's really tied to the substance use disorder epidemic. People who under the influence of drugs do not make good decisions on their sexual activities. And I think that's one of the drivers. But a syndemic is the core principles of a syndemic is the clustering of two or more conditions in a specific population. And when these conditions, which are epidemics, collide, the outcomes of each individual epidemic is much worse than if the other epidemic had not collided with it. For example, when you have patients, an epidemic of HIV and an epidemic of hepatitis C, when they collide, the outcomes of HIV are much worse than if the Hep C wasn't there, and vice versa. The outcomes of hepatitis C are much worse at a population level, at least, than if the HIV epidemic wasn't there. But the most important thing is that these epidemics are trigger-driven and maintained by structural, social, and behavioral factors. And an example of a structural factor would be like there's no harm reduction programs in your area. So even if someone wants to get clean needles, they can't, and they have to share, and they increases bloodborne disease transmission. Social factors would be not having health insurance, not having education and knowledge about what's going on in your community from an infectious disease point of view, or being unemployed, etc. And behavioral factors are more like shared beliefs of certain conditions. We saw that a lot with COVID. Or for example, could be sharing needles, not because of a necessity, but because of a cultural or habit thing that you're doing, and that may drive it. So when these things happen, then you get one of these epidemics coming, and then the other ones start appearing and evolving and maturing and interacting with each other, and you have a problem. And if things were not bad enough, we then had COVID come and muddy the waters here, and it complicated all the other epidemics. I mean, people during COVID, a lot of people did not have access to healthcare, could not engage in care, could not get their HIV diagnosed or treated, or their hepatitis C diagnosed or treated, and that made things even worse. So when you're looking at substance use disorders, there is a subset of people, and I'm sorry, there's a typo there, that are injecting drugs, and they have different complications than the ones that only have a substance use disorder but are not injecting the drugs. So the ones who have a substance use disorder, which is all of them, they're at higher risk of syphilis, chlamydia, HIV, Hep C, and HBV, because these are sexually transmitted. But if they're also injecting, then they have complications that are related to the trauma that the needle causes in the soft tissues. They can get complicated with infections that they can spread through the blood, hit your heart, and you have endocarditis, or hit your joints and you have septic arthritis, etc. So it gets a little bit complicated. Okay, a little bit about human trypanomatosis. So syphilis is one of the trypanomas that are out there, and it's caused by Treponema pallidum species pallidum, and it's globally distributed, it's sexually transmitted, and it's vertically transmitted. The other trypanomatoses, which are called endemic trypanomatoses, have defined geographical areas that you can see on the map on the right-hand side where they are happening. There are three types. They're Yos, Begel, and Pinta, and they're caused by all Treponema pallidum, but other species of Treponema pallidum. The species are depicted in the graph there. Now, these trypanomatoses usually occur in childhood. They're usually not usually, but can be sexually transmitted, but they're usually just contact of skin, abrased skin with contaminated with other, with another person that has an ulcer. And kids, mingle a lot within each other, and that's why they get infected pretty easily. And there's no evidence of vertical transmission, so they don't cause congenital disease. But interestingly, they have the same serologic response that syphilis does. So if someone comes from one of those areas, they could have a positive treponema pallidum antibody and an RPR. Doesn't mean they have the syphilis that we're used to seeing. So this is not common that you will see it, but just have in mind that if you see a skin or a mucous ulcer in someone that looks like a chancre, and you have a treponema pallidum positive, but they come from one of these areas, it could be other types of treponematosis. At the end of the day, you treat them the same way, so no harm is going to be done if you detect that there's a treponema infection and you treat it, but I just want to make you aware of that. So all these treponema pallidums have a common clonal origin, same ancestor, and that's why they're genetically very similar, and that's why they you get the same immune response that we see with the syphilis that we have in our in the Western Hemisphere. And as I mentioned, infection occurs through traumatized or exposed areas, and you can see on the right-hand side different photographs of different types of these treponematosis. You can see there's mainly it's mucosal or skin ulcerations that may occur, and they usually without treatment, although they can cause some structural damage in the areas they're infecting, they tend to resolve, but of course treatment is better. So syphilis, there's still a debate if it's an American, I mean the Americas, North, Central, and South America disease that was taken back to Europe by the sailors after Columbus colonized America, or actually it was there in the old world in Europe before they came, and it was just not detected or noticed. But there's a lot of, the history is very interesting, and I won't take a deep dive, but there's a lot of studies on mummies, on skeletons from, the pre-1400 era, in which they found some things that could be syphilis, but they're not sure it was actually syphilis. Anyways, I don't think it matters at this point too much, but people tend to blame each other for things, and maybe settling this will solve that blaming. So talking about blaming, so syphilis was actually, the name of syphilis came from a Italian physician poet called Girolamo Francastoro in 1530, and he was a very prominent guy at that time, and he had a poem would describe a tale about this shepherd called Syphilis in the poem, that he apparently got upset at the god of the sun, and the god of the sun, in revenge because he got upset with him. Yeah, never get upset with your boss, let me put it that way. Gave him this horrible disease called syphilis, and that's where the name comes from. You also know it as the great imitator, because it was this term apparently came from Sir William Osler, and it's because it can present in many ways that it's deceiving, and I'm a witness of that. I've seen patients recently in the hospital that I've been consulted for septic arthritis, for example, and it ends up being syphilis and not septic joint. Or it can present with acute hepatitis, and you're looking for hepatitis A, B, or C, and it ends up being syphilis. So sometimes it's difficult to nail it down just from the clinical presentation beyond the typical manifestations. And the first outbreak was reported by the French troops in Europe during the war with Italy. Interestingly, the French called it the Italian disease, and the Italians call it the French disease. Again, blaming back and forth who brought it to them. Also, it's interesting to know that although we know that syphilis existed clinically since the 1400s or 1500s, it was not until 1900s that actually a scientist, a zoologist from Germany, was able to see the treponema pallidum that you can see on the slide on the left as those little black, like corkscrew organisms that are there. And how did he do that? He grabbed some secretions from a chancre of a genital ulcer of a patient and injected it into a rabbit's testicle, of course, killed the poor rabbit, and then did a silver stain on the testicle cells, and he can see the treponema pallidum proliferating there. But that's not very helpful for clinical diagnosis, because you're not going to have rabbits in your office and start injecting their testicles every time a patient comes in. So another year later, Carl Landsteiner developed dark field microscopy, where you grab the secretions from a chancre, you put them under the microscope with a special type of light and lenses, and you can see the Treponema pallidum, which are these white corkscrew organisms swimming in a very specific way. And that was what we've used for early diagnosis until, I would say, 20 years ago. So you won't see this very often because people are not trained and the labs have moved into other types of tests. But this was a pretty good test in its time. So around the same time, 1906, everything happened, 1905, 1906. Another researcher was able to detect antibodies against syphilis. It was the first test was a complement fixation test, and it was a tube dilution, which is also not easy to do at the point of care level, but you could do it in the lab. And what he was detecting was what we call today the RPR, which is antibodies against a cardiolipin. Now, he thought they were specific, meaning these antibodies are against the Treponema pallidum, but actually these antibodies, most of them were against these cardiolipin antigens that were in the endothelial cells in the tissues. So that when the tissues get disrupted, they liberate these antigens called cardiolipin, and your immune system produces antibodies against them. So then about 20 years later, or a little bit less, a flocculation test was developed. That's basically what we use today, the RPR. You can see it down here. It's a card. You put a drop of patient serum and a drop of the antigen. And then if the patient has antibodies against this cardiolipins, then it'll flocculate and you can see a positive test. You see these little, clumps of materials there. That's what we use. And in 2018, it was noted that these cardiolipins also are in the Treponema pallidum on the organism. So the antibody reacts, your immune system produces antibody against these cardiolipins, which are mainly in the tissues, but are also present in the Treponema pallidum organism. Now, they're not specific, and that's why you see them in other diseases that disrupt the endothelial cells and can cause these antibodies to go up. So you'll see false positives in pregnancy and autoimmune disorders like lupus, etc. Okay. So what are we trying to prevent? Well, this is our main goal. It's not to have a baby with congenital syphilis. I don't think this should be tolerable, especially when we have effective treatments that could prevent the mother from infecting the baby if they are diagnosed appropriately. And that's why IHS and CDC, especially IHS, is recommending testing the pregnant female 3 times. At the first visit, at week 28, and then at delivery or week 32. So we're trying to prevent on the left, there's a baby with syphilis rhinitis, and on the right is a baby with an infant with this disseminated syphilis affecting their liver, spleen, abdomen, and also the bones. You can see the periostitis there. So this is just a case of to highlight the approach we should have with these patients. So this is a 20-year-old cisgender female who has sex with a cisgender males, and she comes to your office just for a pregnancy test. And she reports she has oral and vaginal sex without barrier protection 3 weeks ago, and she has 2 partners, different partners. And she doesn't have any signs or symptoms of anything. She looks healthy, and she's never been tested for HIV, but has been tested for syphilis about 11 months ago, and the tests were negative, as well as chlamydia and gonorrhea. She denies any drug use at that moment, but she has a history of injecting drugs. Okay, I didn't put that here, but she had a history of injecting drugs 3 months prior. She had injected, 6 months before, 3 months before she had injected heroin. So she also reports unstable housing, no transportation, and irregular access to phones. So she's in the office. The pregnancy test is negative. She does agree to get an HIV and syphilis test, and the HIV is non-reactive, but the syphilis, which is a Treponema pallidum antibody on a point of care test that we use, is reactive. So the question is, what do you do with this patient? No further testing is necessary since she came for a pregnancy test. She got it, so she can go home. Of course, that's not the correct answer. That's the only one that's really incorrect. Never do that. But then there are viable options, draw serum for HIV, test for gonorrhea, chlamydia, and urine and her throat, draw an RPR, wait until you get the results back, or draw an RPR, but treat the patient immediately for early syphilis. Or the last one is draw an RPR and treat the patient for latent syphilis, which would be 1 shot of penicillin every 3 weeks. I'm sorry, every week times 3 weeks, so a total of 3 shots. So syphilis, as I mentioned, is a bacteria called Treponema pallidum and causes horizontal or sexual transmission and vertical transmission, mom to baby. Average incubation period is 21 days, but it can range from 10 to 90, and that's what makes it hard sometimes to diagnose it with serology early, because serology will probably not be positive if the patient is presenting on day 10. And it has 4 stages that we will go over them in the next few slides. So here you can see at the left, there's an exposure, incubation period 9 to 90 days, and then the patient presents with primary syphilis, which is usually the chancre in the mucosal areas, either the genital or other mucosas or skin. And then it will resolve spontaneously, even without treatment. And that's the problem. The patients will get better and maybe they will not go to see their provider. And then if they're not treated, they may manifest with secondary syphilis, which we'll see some pictures about that. And then again, without treatment, it resolves. And then you go to an early latent phase in which the patient's asymptomatic. And the only way you can diagnose it is by testing their blood for antibodies. And there's this magical, I call it magical because I'm not sure where the science came from to say 12 months is earlier and more than 12 months is latent. But let's accept that that is true. So if it's within the first 12 months, the infection is in the early, this is all early syphilis. And if it's after 12 months, it's late syphilis. But the important thing to understand is that neurosyphilis, otic, and ocular can occur at any stage. So you can have someone with a primary syphilis and have neurosyphilis or have ocular syphilis. And that's why it's so important to ask questions about symptoms. And of course, if the patient's untreated, years later, 10, 20, 30, they end up with late complications, which is neurosyphilis, that we mainly see it as dementia, or cardiovascular syphilis, which we mainly see it as aortic aneurysms, or late ocular and otic syphilis with, visual problems. So primary syphilis, the typical manifestation is the chancre, which is an ulcer that is usually round, firm borders, painless, and clean at the base. But not all Treponema pallidums read the book, and sometimes there are multiple ulcers, they're painful, and they're not so clean at the base. So just have that any ulcer in a genital area should trigger, this could be syphilis until proven otherwise. And again, 3 to 6 weeks later, it can go away. Sometimes it's very visible because it's on the penis, for example, or on the tongue of that patient. They'll notice something weird on their tongue. But in females and in men who have sex with men, it could be like within the inner labia and you won't see it, or in the cervix and you will never see it unless you do a colposcopy, or it could be in the anal canal. And since it's painless, the person may not notice they have an ulcer there. And that's why it can go undiagnosed. Now, let's say the patient resolved the primary syphilis without treatment, and then they come back with secondary syphilis. So the typical manifestation is the rash. And the rash, usually it's a macular rash, which doesn't itch, and it goes away by itself. And the typical presentation is in the palms of hands and soles of feet. That's very typical. Not 100% specific for syphilis, meaning other things can do this. But if you see this, that is syphilis until proven otherwise. And actually, I would venture myself that in the right setting, I would treat a patient even if I don't have a lab test available for syphilis. But it can also present as alopecia. And FYI, my alopecia is not due to syphilis. I'm just getting old. Or it can present as condylomas, which are like flat mucus plaques in the genital or area, or even in the oral cavity. And they're very infectious. So every time you're touching any of this, you have to have gloves on, which today is common practice, but in the past, it wasn't so common. So Okay, so latent syphilis. So remember, primary is when you have the chancre, secondary when you have those rashes. Now on secondary syphilis, I forgot to mention, let me go back. On secondary syphilis, you can also have other manifestations like arthritis or a hepatitis or any itis. Any inflammation of every organ could be a manifestation of secondary syphilis. Now, when you go after primary and secondary, you jump into latent. And if it's, as I mentioned before, if it's within 12 months of the infection, it's called early. And if it's after 12 months, it's called late. Now, how do you tease this out? Because this, when you start doing universal screening, most of the syphilis that you will diagnose are going to be latent syphilis because patients are coming in for something else. They're coming in for, they have hypertension or whatever. You're screening them. Suddenly a TP antibody pops up positive and an RPR pops up positive, but the patient has no symptoms. How do you differentiate this? So this is history taking. So you have to ask the question, in the last 12 months, have you had an exposure to someone with syphilis? And if they say yes, then that's early syphilis. In the last 12 months, have you had an ulcer on your penis or on your genital tract or in your mouth or anywhere that nobody could diagnose and went away by itself? And they said, oh, yes, 4 months ago, I had an ulcer on my penis, but it went away after 2 weeks. Okay, that's syphilis. So that's early syphilis. But if they cannot, or if they told you, yeah, I had syphilis 6 months ago and I got treated, then that's also early syphilis that was treated. So you have to ask those questions. But if the patient says, no, I don't recall an exposure to anybody with syphilis. I never had any symptoms of syphilis in the last 12 months, a rash or an ulcer, and I've never been treated for syphilis, then automatically that becomes latent syphilis. So it's by default. So that's why you have to ask those questions and figure out what's going on. Now, someone could have had syphilis 6 months ago, and now they're reinfected again. So it gets sometimes a little bit messy and complicated. But that's how you have to tease out looking at the labs, the titers of RPR, what's going on, and we'll get to that. So tertiary syphilis, we don't see this very often. Why? Because a lot of people get antibiotics for other reasons that may be treating syphilis. Like you get amoxicillin for 2 weeks for 10 days for a strep throat. That may cut it in some cases to treat syphilis. Not that I'm promoting that's the way you treat it, but a lot of people get exposed to antibiotics in the hospital for weeks. And if they had syphilis, it would be treated. But if they never got it treated, what you will see today is patients with dementia. I mean, I get called. I was working up this patient for dementia, and an RPR came back positive, and then you ruled out other causes of dementia, and you say, okay, this is probably syphilis dementia. But it can present as chronic ulcers in the skin. It can present as aneurysm in the heart. But we don't see that very often as we did like 30 years ago or 40 years ago. Then you have neurologic manifestations. They can occur at any stage of syphilis. So that's why you have to, even if the patient comes in with primary or secondary or early or latent syphilis, you have to ask them questions. You have to ask them, are you having any, basically you're looking for neurological signs or symptoms that you cannot explain by any other disease. So of course, someone has Parkinson's and comes with a tremor, you're not going to say that tremor is just syphilis because they have Parkinson's. I mean, not that they couldn't have syphilis, but it's just a question of probability. But if the patient doesn't have any neurologic disease and they have a severe headache and that's been going on for weeks or months, and you cannot nail it down what that headache is being caused by, then that's syphilis until proven otherwise. Numbness or paralysis of a limb, etc. Ocular syphilis, ask the patient, are you having any visual problems at all? If they say any visual problems, I don't care if it's their myopia that's not been adjusted recently, send them to the optometrist or ophthalmologist, have them do a fundoscopic exam, and they can tell you if the patient has ocular syphilis. They're really good at doing that. Actually, I have had many patients sent by the ophthalmologist. They say, hey, this patient came for a routine eye exam, and when I did this fundoscopic exam, I saw a lesion that's compatible with syphilis. And actually, they've never been wrong in my experience. When I test them, they have syphilis. And then autosyphilis, if they're having hearing issues, vertigo, balance loss that you cannot explain by any other condition, you need to assume that that's otic syphilis. So a little bit about congenital syphilis. So it can be transmitted. It is transmitted through the placenta while the mom is pregnant. It can also infect the baby when the baby is being born. If the mom has primary syphilis, let's say that she has a chancre in the cervix or in the vaginal canal, then the baby will touch it and can get infected through that mechanism, but it does not cross it's not transmitted through breast milk. But if the mom has a lesion on her breast, then that could be a contact that could transmit it, but not the milk itself. So when it can occur at any stage of syphilis, but it is most severe it is most severe in the first trimester of pregnancy, but it's most transmittable at later trimester. Meaning, if the mom gets syphilis in the third trimester, it's more likely to pass it to the baby compared to if she has it in the first trimester. But if she passes it to the baby will suffer more complications the earlier it gets infected. When the mom has primary or secondary syphilis, the rate of transmission is extremely high to the baby, 60 to 90%. Early latent, 40%, late latent, 10%. And after 4 years of non-treated syphilis, it's about 2%. So what are the barriers that we face on the diagnosis and treatment of syphilis? So there are risk factors, moms who have poor access to prenatal care, lack of syphilis testing during pregnancy because the providers are not trained to do it, or the test is getting done, but nobody follows on the test. Or if the mother is co-infected with HIV, it's also higher risk of getting syphilis. And so I don't have the epi slides, but the bottom line is that Native Americans have the highest rates of primary, secondary, and congenital syphilis compared to non-Native population in the United States. And that syphilis has been increasing across the country, regardless of your ethnicity, in the last 10 years. And the cases of congenital syphilis have increased tenfold in the last 10 years. So we got a big outbreak of syphilis. It should be, in my opinion, called an emergency. And I'm trying to get the Cherokees to call it an emergency. Because, if you go into a household and you treat the mom, but you don't treat the dad because he's not Native, things are not going to work well. You need to treat everybody. And then there are social vulnerabilities. So people who are homeless or houseless, I'm sorry, I think the term is changing to houseless and not homeless. Substance, I'm sorry, that's a typo on my end, and I should have never put that word substance abuse. It's substance use disorder. Or people who are incarcerated, they're all at risk of syphilis, as of many other things, but syphilis included. So the screening guidelines, the CDC is tricky because they recommend, at the end of the day, when you read the fine print, you would basically be screening everybody. But if you don't read the fine print, you won't. The IHS, I think, was much more clear and says everybody 13 years and older, let's just screen them for at least 2 consecutive years or until the outbreak is mitigated. And turn on your annual electronic health record reminders at all sites. And on pregnancy, provide 3 points of screening, as I mentioned, at beginning, week 28 and 32. But turning on the electronic health care reminder does not cut it for everybody, and it'll improve, but the magnitude of improvement is the way you set it up in your system. That's why I was telling you, maybe you need to really make sure who's actually, I don't know, Anna, maybe if you can, I don't know if you can pull the data of how many people have the electronic health reminder active, like turned on, because if they get screened, it would be automatically off for at least for a year. So maybe if you can dig it that way, you will get an idea of how many people actually had their reminder satisfied. Just a thought. Maybe it's not possible in your system. I don't know, but yeah, it's complicated. I'm glad I'm not doing your job because it's too complicated for me. Okay, so this is a list of treponemal and non-treponemal tests. So the non-treponemals are the RPR. VDRL, which is the same type of test, but we only use it for CSF, for cerebral spinal fluid. In blood, we do RPR. It measures antibodies against the cardiolipin cholesterol lecithin antigen that I mentioned, that's mainly in your tissues. It could be qualitative or quantitative, meaning you can get it titer, and you can use it to follow response to therapy. So the titer should decrease with time. The treponemal pallid antibodies are more specific, they're qualitative, They're not useful for following up the treatment response because they will be positive all your life. And the false positivity rate is much lower. And on the top, I mean, there's a bunch of treponema pallidum tests. Basically, each one is targeting a different type of antigen of the treponema pallidum organism. And those subtle differences make it a little bit different, each one from each other. But essentially, they are specific antibodies against the treponema pallidum. And you have, enzyme immunoassays, fluorescent assays, treponema pallidum, particle agglutination tests, so different types of ways you can do that. So this is a very, I think this is from CDC. It's a really great graph because on the solid line is RPR. I'm sorry, on the solid line is the treponema pallidum test. On the dashed line is RPR. So you can see that the treponema pallidum test pops up earlier, so it's more sensitive earlier in the disease. At 2 weeks, it starts coming up. The RPR takes about 4 weeks to start coming up, and then it goes up, and then it stays high for most of your lifetime, regardless of treatment. That's why it's useful. Once it's positive, don't order this test again because it's always going to be positive, regardless of treatment. But the RPR goes up, and if you don't treat the patient, stays at high titers for the most part. But if you treat the patient, it comes down. 80% will be negative, meaning patient seroconverted. There's no more RPR to detect. But about 20% will still have a low titer, which is called serofast. And that sometimes it's puzzling for providers. What do I do? I have a RPR 1 to 4 or 1 to 2. So it all depends on what their baseline was, and we'll go over that in a minute. So there's two algorithms, the traditional one in which we started with RPR and then reflex to treponema pallidum antibodies if it was positive. So you did an RPR here, it was positive. You would do a treponema pallidum antibody, in this case is TPPA, which is particle agglutination test. And if it's positive, you say, okay, patient has syphilis. And if it was negative, you would say, okay, that RPR is a false positive. But now what we're using is the reverse algorithm in which we start with the treponema pallidum antibody. If it's positive, then we do an RPR. If it's positive, it's confirmed. But if it's negative, you have to do a different treponema pallidum antibody test. And if that's positive, that means the patient does have syphilis. The RPR is just not detectable. Or had syphilis and was treated. It could be either way. It doesn't mean that it has active syphilis, but that they have been exposed to syphilis at some part in their lives. So this is the one we're using now. It's better, I think, because it's more sensitive. It pops up earlier during the disease, but it also creates more patients with positive tests that you have to deal with. And this is just to show you, not to confuse you, but you can see the non-treponemal test, and then you can see the early treponemal test and the enzyme immunoassays and the immunochemiluminescent assays that we have today. All these are treponemal tests. But when you look at the sensitivity, it's extremely high, 100% for most of these tests. I'm sorry. In secondary syphilis, they're all 100%. So the message here is if you see someone with a rash and you do a treponemal or a non-treponemal test, for the most part, if the test is negative, the patient does not have syphilis. But when you look at primary syphilis, you see that the sensitivities are 70, 80, 90, 70. They're not perfect, but the one that we're using mostly to screen patients, which is this one, is 100% sensitive. I never believe 100% to be true, but let's say it's 99. And the other one, the immunochemiluminescent assay, is 98. So they have really good sensitivities. So they're not perfect tests. They have false positives. The RPR has much more false positives than the treponemal test, but we are seeing some false positive treponemal tests. Now that we're screening a lot of people, massively screening, you'll pop up with more false positives. And these are, I'm not going to go into detail, but these are the conditions. And remember that pregnancy can be a cause of false positive tests. So that's where it gets a little bit more muddied. And usually when we're in doubt, we just treat. And I think either it's better to err on that side. Okay, so these are all lab-based tests, the ones I mentioned, but now we got point-of-care tests. There's two main point-of-care tests, the health check and the ChemBio. We are using at Cherokee Nation the ChemBio for several reasons. First, it's got a reader, so it doesn't depend on the human eye to say it's positive or negative. You know, people sometimes get confused, and not everybody interprets it the same way, but here it's more objective. And second, you can get an HIV test. So you get an HIV and an RPR on the same test. And that's the one we're using for point of care. So we are, when people come to our health system, they're mainly getting the blood test for screening. We are using the point of care only to screen at as outreach, like when we go to the harm reduction site or the jail or the homeless shelter. That's the one we use. But in the hospital, in the clinics, or in the ER, we only use the rapid test for people that you suspect have syphilis. Like they come with a rash, they come with a chancre. That's a quick 10-minute test, 15-minute test to get a result back. Because the other are send out labs, and like you mentioned on your system, and that they take days, to come back. So I don't think it's cost effective to screen in-house with this. Well, unless you want to spend the money, but it's a really good test to screen people who otherwise will not come to your clinic, or who you suspect have syphilis, and you want a quick test to treat them. Because the treponema, the syphilis test embedded in these two tests are treponema pallidum antibodies. They're very specific. So if you have a positive test and the person says, no, I've never been treated for syphilis, then you can treat them just with this test. The HIV, of course, you have to reflex it to confirmatory test. But the syphilis test, as long as the patient has never had syphilis, you can go ahead and treat the patient with this test. And I just want to explain this a little bit more. For example, if a patient tells you, oh, I had syphilis 3 years ago and I got a penicillin shot for it, then the test is going to be positive. And that's why then you'll have to order an RPR to see if the titers are high or not. So treatment, rapid treatment is like treat it as soon as you get the results. Like you're using the point of care test, you have a TP antibody that's positive, and the patient has no history of syphilis, treat them there. Presumptive treatment is you see a patient with a chancre, for example, primary syphilis, and you know that some of these tests may be negative if the incubation period was very short. Let's say the patient presented like 11 days after he got infected, and we know by that graph that the best case scenario, it takes 2 weeks for these tests to be positive. So you have to treat clinically. I mean, if you think the patient has herpes and it looks a lot like herpes and has a history of herpes, okay, that's fine. But if you can't be sure that this is not syphilis, you treat it. Or someone tells you I was exposed to syphilis, then you treat it empirically. You draw the labs, get all the labs cooking, but you treat it immediately. And then there's targeted treatment, which is based on laboratory tests. That's like when you're screening and you get a positive RPR or a treponema pallidum, and you treat based on labs, not based on symptoms or exposure. So these are the kind of the three categories. The treatment is simple. I mean, this is a simplified chart, but the main message is use penicillin. Early syphilis, which is primary, secondary, and early non-primary, non-secondary, is 1 shot of penicillin. 2.4 million units of benzathine penicillin G. Late syphilis is weekly shots times 3. And you take care of all the late latent. But if you have neuroocular or otic syphilis, that's an IV treatment. You give IV penicillin for 10 to 14 days. So that's more complicated because it usually requires admitting the patient at least for a few days until you can get the insurance to pay for continuous infusion of penicillin at home. But have in mind that that's the bottom line. Now, if the patient's truly allergic, you can use doxycycline for early and late latent, but not for pregnancy, not for neuro and otic or ocular syphilis. For those, it's only penicillin. So if the patient's truly allergic, you'll have to desensitize the patient. That means you bring him in the hospital and you implement a desensitizing protocol. So I'm not going to go in the details of this graph, of this slide, I'm sorry, but just to tell you that there's no shortage of penicillin for, at least for sure, for native people. So do not use doxy as an easier way to prescribe treatments, because this is the best treatment. And if they're truly penicillin allergic, you can use doxy as long as they're not pregnant, as long as they don't have neuroocular or autosyphilis. But the majority of people who claim to be pen allergic are not pen allergic. Now, to rule that out, it's a little bit more complicated, and that would be a different talk. But we use an app that's called PenFast. It has 4 or 5 questions. You answer those questions, and it tells you what is the risk of this patient truly being allergic to penicillin. And then you can opt out. You can opt for either, desensitizing them or giving them an oral challenge of amoxicillin to see if they're truly allergic in a controlled environment like the urgent care or the emergency room, or your clinic if you have a crash cart and everything available. So follow-up testing, this is the important thing. So you do an RPR, you get a titer, and then you expect that titer to decrease 4-fold within the first 12 months for early and early latent syphilis, and within 24 months for late syphilis or patients with HIV. So if your titer is 1 to 32, you expect it to go to 1 to 8. If your titer was 1 in 512, you expect it to go to 1 to 28. That is a good response. Now, I don't feel very comfortable with someone running around with 1 into 128, so I expect them to decrease with time, but you don't have to panic as long as it's decreasing 4-fold within this time frame period. The problem is this is very important. A patient comes to the ER or goes to the clinic, gets a lab for syphilis, goes home. 3 days later, you get your results back. Oh, the patient's positive, has a positive troponin antibody, has an RPR of, let's say, 1 to 32. Okay, bring him in. Takes 4 or 5 more days for the patient to come in. He's there like 10 days later. You give him the penicillin shot, but you don't obtain a new RPR. And what happens that RPR that was 132 10 days ago now can be 1,256, and that's your baseline. So you have to obtain a new RPR when you're treating the patient, because that's the one you're going to compare it with. Because what can happen? Let's say the patient, when was diagnosed, had 1 to 32. He came in 10 days later, in which in reality he had 1 in 256, but you're using 1 to 132 as your baseline. Then 6 months later, the patient comes and he has 1 in 64, and you're saying, oh, it's going up. No, it's not going up, because originally it was 1 in 256 that you didn't take the blood, and now it went down 4-fold. That's the simple message is, unless the patient had the results done the day before, repeat the RPR the day that you're going to treat the patient, just to have your baseline up to date. This is just a syndemic concept that syphilis is what we're targeting, but patients at risk for syphilis are at risk for gonorrhea, chlamydia, hepatitis B, hepatitis C, it's pregnancy, etc. So bundle all the tests and make sure you screen them for all the other conditions that are sexually transmitted or are transmitted through injection drug use in case your patient is injecting. Just 2 words on HIV pre-exposure prophylaxis. So if you have syphilis, you're a candidate for HIV PrEP, because the same way you get syphilis, you get HIV. So it's not happening. That's a reality. Providers are not offering HIV PrEP on patients with syphilis, but it should be like on their checklist. So usually when I'm seeing a patient, or my providers are seeing a patient in our ID clinic, when they come in for syphilis, they leave with penicillin and Truvada. Unless we offer it to them. Some will refuse it, but at least we educate them and we tell them what's going on. And if they don't change their sexual habits, they're going to get HIV very soon. And that unfortunately happens. And then we have doxy-PEP, which is taking doxycycline after a sexual exposure to prevent chlamydia and syphilis. And gonorrhea, I didn't mention gonorrhea because it doesn't have a great impact on gonorrhea, because most of them are resistant to doxy. It might have a mild impact, but you can reduce syphilis transmission by 70% and chlamydia transmission by around 70% when you take this within 72 hours of the exposure. Now, this is only recommended right now for men who have sex with men or transgender women. It's not recommended for cisgender women or transgender men. Why? Because we don't have enough data that supports the efficacy. In my practice, I don't deny it. If I have a female who heard about this and they're at risk and they're wanting it, I'll prescribe it. I'll just say, okay, we don't have enough data that it works, but it's a pretty benign medication. So I'm happy to, offer it to you until we have more data. That's my policy, not the CDC or IHS policy. So the female that we saw in our case presentation at the beginning, that she had a positive treponema pallidum test. And so the important thing is to pay attention to the details, like, she denies drug use, but injected heroin. She doesn't have a phone. She doesn't have a house. So what do you do with this patient? So certainly you draw blood for an HIV because the HIV point of care is not perfect. And you test them for gonorrhea and chlamydia because she could have acquired them the same way she got syphilis. And then you draw an RPR, but you immediately treat her. Why? She's not going to come back. You won't be able to reach her. She's pregnant. And that's the best way to prevent that congenital syphilis case from happening. The last option is not true because the patient was negative for syphilis 11 months ago. She had been tested and she was negative. So that puts her in an early latent situation. If she had not been tested, then you would know and you would have to treat her as late latent, but you knew she had a negative test 11 months ago. And of course, the first one is like, if you do this, I'll fire you in my clinic because you shouldn't have done that. The patient comes in for a pregnancy test and tells you all these other risk factors. You should, do everything. So one-stop shop or no wrong door. You should cover all the problems. And that is it. I think Anna covered very nicely the epidemiology, given local data, but that's what we're seeing in the big picture. And it's basically, we have a rise in syphilis, a lot of congenital syphilis. And this is very connected to the substance use disorder epidemic. And we need to embrace that as a syndemic. And that's it.
Thank you, Dr. Mara. Do we have any questions regarding syphilis? Yes, Jewel.
Yes, thank you, Dr. Mara. I have a question. You stated that the individuals who test positive for syphilis at where you see patients, they're automatically candidates for HIV PrEP. Is that something that physicians are alerted to automatically do through Cerner? Like, how do you all...
No, I wish. That would be a great thing. So we're trying to, so I don't know if you guys heard of First Line, the app First Line. I have to jump into a workshop now, but I'm happy to sit down. We're adopting that. It's an app. Actually, if you go to the App Store and type in First Line, you should see something like this. I think give me a second. Give me 1 second. Let me unblur my background. Okay. You should see something. Okay, the logo, it's this little thing. Okay.
Mm-hmm.
So it's an app that Turkey Nation, we're launching it soon, and it gives you can download it. I mean, you don't have to pay for it to download it. You just don't have your site. You can and you won't see the Cherokee Nation site now because it's not gone live yet, but you'll see it in a couple of weeks. And for example, see, we have all these guidelines there, and then and for example, we've developed a syphilis guideline. Okay. And so it makes it easy for the providers because you answer questions. It says, for example, does the patient have a positive treponema pallidum and RPR? And you click yes. And then it asks you, has the patient been treated for syphilis? So all the things I went over, it's kind of walking you through it. And one thing that we have to add to this is that what you're mentioning is, has the patient been offered HIV PrEP? And if they say yes, fine. If they say no, okay, you should, and these are the questions you should ask. But no, unfortunately, Cerner will not trigger it. Now, you could make Cerner trigger that because our providers are used to using power plans, what makes their life easier. You have syphilis, you click the syphilis power plan in Cerner, and it'll say, okay, this is the treatment, and this is what I want. And you can embed in that power plan a question saying, has the patient been offered PrEP? But no, we're not doing it. And unfortunately, most of the providers I would say that most by now know what HIV prep is, but they have not embraced it. And it's a hard sell. And don't ask me why, but it is a hard sell. And so we've been going around this up and down, trying to get pharmacists to do HIV prep. So it offloads it from the provider, had some success there, have looked at champions in each clinic that would do it, had some success there. So we increased our prep from having like, it was 14 patients on prep 5 years ago. We have 90 patients on prep now, but we should have 500 patients on prep to be, be more effective. But yeah, that should be there. That's a
Thank
good
you.
point.
Thank you.
Anna, you had a question?
Yeah, this is more of a, I guess, curiosity. You had mentioned potentially prescribing women doxy prep or doxy pep. Do you worry that that would potentially like interact with like a birth control and make it less effective? Or how do you kind of weigh those kind of risks or benefits?
Right, no, that's a good point. So every time we prescribe a new medication, we check, we do drug-drug interaction. So if they're having a drug-drug interaction with something else, then we wouldn't do it. Or we would try to change that other drug if possible to someone that's a drug that does not have interaction with the doxycycline. But yeah, I mean, that should be something, and our pharmacists are usually good at picking that up if you missed it. But yes, you have to check on those things. But like I said, that's not a formal recommendation, and we don't even offer it off the bat unless the patient, and we had maybe one or two ask for it. They've read it and they're concerned about it, and we explain, look, this is not standard of care yet, but I'm not opposed. Of course, I cannot prescribe it as that indication. I have to put something else like acne or whatever and give it to them that way. I think you're muted, Brian.
Yep. Thank you, Dr. Mayer, for a wonderful presentation again. Just an announcement, we are not having next month's October's ECHO. We will resume our ECHO in November, but we are also not having our ECHO in December due to meetings that we have previously scheduled. The November session is on respiratory illnesses, and we'll give you some epidemiology for the area as well as some clinical recommendations. And that is all I have. Anybody else have anything? Okay. Well, you all have a great day. Thank you.
Bye-bye.